Hi, good evening, everyone, and thank you for joining for tonight's event. Top 5 clinical tips for a successful contact lens practice with the one and only Dr. Jennifer Stewart. So I'll be your host today. My name is Dr. Ariel Servency. So I'd like to introduce our speaker tonight, but most of you probably already know her. So she is an amazing speaker, an optometrist, and an internationally recognized speaker, writer, consultant, and entrepreneur. She has a passion for helping optometrists and organizations with operations, sales success, practice management, and sales team training through her advisory and consulting firm, OD Perspectives. So we'll get to learn a lot about that tonight on this presentation. She's a professional editor of Independent Strong, is an adjunct assistant professor at the New England College of Optometry, and a consultant for CooperVision, MacuHealth, GPN, and Xyloware. She's also the recipient of the 2022 Emerging Leader Award for the Optical Women's Association. You just got that pretty recently, didn't you?
Yes, a year ago, last year, about this time, right at Vision Expo. A year flies.
Okay, you just got like another award recently, though, right?
Probably.
Well, we're super excited to hear from you, and I'm gonna have you take it away from here.
Perfect. Thank you, and thank you for having me. Sorry, I wasn't ready on the slides. I also am a moderator, so I apparently was in moderator mode for a split second. So it's nice to be on this side of Woo You again, and it is my pleasure to be back for, I think this is my 6th webinar since last year, and it is always my greatest pleasure to be here on Woo You with so many of you. I see you still filing in, and I'm really excited to be here tonight. And I'm so glad you decided to spend your evening. Here are my financial disclosures. So I consult and speak for CooperVision, Xyloware, MacuHealth, and GPN. And for COPE, I love to say that all of the financial relationships have been mitigated. So now that that is out of the way, we can begin. So tonight is the beginning of a 5-part series, and I hope if you're here tonight that you've also signed up for the next 4 webinars as part of the CooperVision series. And tonight, my goal is to set you up to really be successful when you head to your practice tomorrow or Thursday or Friday or next week. And nothing that I'm going to share with you tonight, I believe, is earth-shattering or new. But I'm hopeful that I can encourage you to think a little bit differently when you go see patients tomorrow morning, and think about each person in your chair, not as, my 8 o'clock, my 8:30, my 9, but as an individual and a person, and to really think about their contact lens needs a little bit differently. I love making this interactive. If we were in a big room, it would be really fun because there's a ton of you on here, and I'd have all this energy and lots of excitement and hopefully lots of questions and comments. So I love making this as interactive as possible. So feel free to use that chat and the Q&A throughout the webinar. If there's something that comes up that you have a quick question, or if you want to hold it till the end, there will be a few minutes that we'll leave for some questions. But I don't mind answering on the fly. It makes it a lot of fun. It makes it fun for me to help kind of move this along and make it more interactive. So feel free to put some questions in that chat, and I will get to them as we go. So here's me. Dr. Servency did a great job introducing me. I do a lot. I'm really excited about the work I do in OD Perspectives, helping doctors and companies just be better at what they do every day. And I love being out at meetings and meeting all of you, and hopefully helping you in your practices as well. So I like to start, and this is a great opportunity, don't be shy. But I like to first say, I'm talking about successful contact lens practice, but I like to stop and say, what is your definition of success? So the true definition that I found online is the accomplishment of an aim or purpose. So when we think about our contact lens practices, and feel free to put this in the chat, what do you define as a successful contact lens practice? So I'd love to hear from some of you, even a few of you. Don't be shy. There's a lot of people. So Please feel free to put it in there so that I can hear what you think. A happy patient, great, happy patients. So what else do you think of as a successful contact lens practice, or what makes your next patient that you see tomorrow a success? Returning patients, when the patients wake up excited to wear their lenses. I love this. Fitting the previous contact lens failure, minimal contact lens dropout. What I really like about this, patients that refer others, happy patients refer others, and loyal patients who come back year after year. What I really like about these answers is that there wasn't a dollar amount attached to this. No one so far, and it might be part of what you define as success, but what you're defining as success are patients who are happy with their contact lenses. 20 happy, that is absolutely perfect. I agree. If they're not 20/20 and they're happy, it is a good day for all of us. And keep putting them in there. I love seeing this. Repeat patient. So patients that continually come back to us for some reason. And we're going to talk a little bit about how we can make that happen. And what I like to say is what's good for the patient is good for the practice. So if we have all of these things happening to us where we have repeat patients, happy patients, patients who are referring friends and family because they can't not want to send people to us, that will transfer into increased revenue and increased success in our financial aspects of our practice. So I love all those answers. That's a great way to start. So what are my 5 tips for success? And these are mine. It doesn't mean they have to be yours, but I like to think about what I would say makes, not for a successful patient, because we know what we're talking about, what success looks like, but how do we get those patients? How do we get those patients to feel that they want to talk about their contact lenses to their friends, families, neighbors, coworkers, and say, oh my gosh, Dr. Stewart just gave me the best eye exam I've ever had. She fit me with the most amazing contact lenses there are. You have to go see her. And I can't wait to go back year after year. How do we get there? And contact lenses, each one of us is very skilled at fitting contact lenses, and we all do it very well. But how can we take that practice to the next level? So these are my 5 tips for success. So my first one is to stop. So again, audience participation, if you've heard me talk about this, or actually Steve Vargo, I give credit for this. I learned this from him. But how long do doctors typically listen to our patients before we interrupt them? So go ahead and put that in the chat, what your guess is. How long do we typically zip it and let them talk before we jump in and start talking to them? So 1 minute. Okay, so we've got 1 minute, 2 minutes, 3 minutes. 1 minute, 2 minutes, 8 seconds, 10 seconds, 5 minutes, 5 minutes, 3 minutes, 1 minute, as long as they need. That is a great answer. 20 seconds. So keep it coming. Somebody knows my answer. So Dr. Ciano got it. You've probably heard me talk about this. 30 seconds, 1 minute. The real answer is 11 seconds. So typically, on average, a doctor waits just 11 seconds before interrupting a patient. So now, I'm going to stop talking. For 11 seconds. So that's super uncomfortable. It's even worse when I'm in a big room doing that and I stop talking and we all sit there for 11 seconds. It feels like an eternity when we're sitting here doing nothing and just watching a clock. But is 11 seconds truly enough time for a patient to express why they're here, what their concerns are, what their hopes are, what they'd like to get out of their exam, any questions they might have? We're only waiting 11 seconds before we jump in and start interrupting them. So I love this because 11 seconds can feel like a long time, but if you were the patient and you only had 11 seconds to get everything out that you wanted to talk about, it doesn't feel like as much as it just did. So I love studies and I love finding studies about doctors interrupting people. So I found this great study that was done of 112 clinical encounters. And in less than half of those visits did the doctor actually ask what brought the patient in. And when they did ask, about 2/3 of the time, they then interrupted them. So they only asked them, a third of the time, And then 2/3 of the time, they just interrupted them as soon as they started talking. So that time to interrupt, you were all pretty much in that range from 3 seconds to 234 seconds. We had some who waited a little bit longer, but on average, we are not waiting long enough and not giving the patient enough time to talk about what brings them in. And most of the time, 60% of the time, they interrupted to ask a closed-ended question, not to dig deeper and ask for more, but to shut the patient down and to kind of ask them something that was super closed-ended to stop that conversation. So what can we do about this? I always say, just let the patient talk, do what you need to do, whether that's you sit on your hands, you bite your tongue, you grit your teeth, you count in your head to 11 and keep going, but let the patient talk and let them tell you why you're there. And this is very hard for me. I'm an extrovert. I'm a super excited person. I love talking to people. And I found that once I heard this from Steve Vargo, I said, nah, that's not me. I sit there and I let them go, and I'm really patient. And I got in the exam room and I didn't even sit down before I started talking at the patient. I was washing my hands and I couldn't wait to share all the great ways I was going to change their vision, because I use a scribe. So a scribe had kind of asked them why they were there. But when I walked in, I came in kind of really kind of at them saying, here's what we're going to do. I'm going to do this, this, and this, and this. And I'm so excited. But not once did I actually let the patient talk to me and tell me why they were there. Once I realized this, I had some better control. And I know there was a comment about what about staying on time? This actually helped me get faster, because when I let the patient talk, I was thinking in my head then about what I wanted to do, and I had that plan in place. So I'm not saying that I let the patient talk and wander and meander through their life history for 20 minutes, but I could certainly be thinking while they were talking about what I wanted to do next and what questions I wanted to ask them once they were done, so that I didn't ask them a closed-ended question. So that was a great comment about staying on time. Obviously, we can't let them talk for an hour, but really being cognizant about what we do and letting that patient share what their fears are, what their goals are, and using that to frame how we're going to fit them with contact lenses and what lens choices we're going to make. And as we talk about some other of my tips for success, some of the choices that we make are going to be more expensive. But if we use the patient's own wording and what they phrased and why they're here and what struggles they may be having, that can help get them on board more. So know your numbers. So when we look at a typical contact lens practice, I think a lot of us think about contact lens patients as our younger patients. I know I certainly did. And when I was thinking about this presentation, about who I want to address in a practice and how we could all be more successful in increasing the patients that are wearing contact lenses, increasing the types of lenses that we're fitting, and overall becoming more successful, as we mentioned, having more patients refer, having happier patients. A typical practice actually is a little bit different than I thought in the number of patients who are wearing contact lenses. Our younger patients do make up about half, so 18 to 34. But when we look at the older demographic, and I hate to say older because I'm now almost in that white block, but we think about our presbyopic patients. I'm 42, so I'm moving slightly in that way, but there's such an opportunity that we have with our pre-presbyopic and presbyopic patients, and they make up a significant part of our practice. Here we can see they make up about 1/3 of the patients who are wearing contact lenses are patients who might have different needs. So thinking about them differently, I know that they can be more challenging and the chair time can be much more significant, but those patients are really looking to us to guide them into their needs and to really address some of the concerns they have. And surprisingly, or not surprisingly, a lot of these patients are coming in with questions and leaving without answers. So again, my hope is that tomorrow, when you see these patients, you hear my voice in your head and say, okay, I'm going to do a little bit better. I'm going to stop talking, let this patient talk to me, and then I'm going to present the tools that I have to get them to be more successful. So be mindful of who's wearing contact lenses. And if you were to go to your demographic of patients tomorrow and it doesn't look like that, if you have a significant drop off as patients get to presbyopia or beyond, and you have a very small number of patients who are wearing contact lenses who are presbyopic, that might be your first clue that I have to do a little bit better there. I have to maybe use some of the newer materials that are available, the newer designs that help our patients be more successful quicker. And just maybe I'm just not identifying those patients as contact lens wearers. So being mindful of the demographic of the patients who are wearing contact lenses. What are your patients' trends? Do you see more patients? I know during COVID, there was a huge push to wear contact lenses and new wearers. Are you still seeing that, or are you seeing a drop off? Is that similar to other practices in your area? I love talking about the slow dropout, because we are always mindful about patients who stop wearing contact lenses. They come in one year and say, I'm done. I'm a glasses only patient. For whatever reason, it didn't work. For me, I was always on the hunt for these slow dropout patients. This would be the patient who, like clockwork, they're our favorite patient, because every year on February 7th, or plus or minus a day, they come in, they purchase an annual supply of contact lenses. Every year they are like clockwork. I could set my watch by them. But in 2023, maybe that patient comes in, and when you just automatically assume you're going to order the year supply, they go, oh, you know what, Dr. Stewart, I'm good for now. I realized when I was coming in, I've only used half of the boxes of contacts this year. You know, I haven't been wearing them as much. I've been wearing my glasses, and, you know, it might be easy to say, okay, that's great. You got a great new pair of glasses this year. Who wouldn't want to wear those more, and kind of move along? In 2024, that patient comes in and goes, oh my gosh, you know, I realize I still have a box per eye of those lenses, and they're not expired, but I don't need to order contact lenses. I've still got them, but I'm wearing them less and less. Is that patient a dropout patient? Maybe so. Maybe they just find they're only saving those lenses for special occasions for some reason. That could be dryness. It could be the quality of their vision. But that's somebody that I would dig deep into, saying, you're not going to offend me. What aren't you telling me? Are you not wearing your lenses because you're finding at the end of the day they're drier? I've got a solution for you. Or do you find that now that you're 42, it's easier to wear your glasses because you're a -3 and you can just take them off to read? Is that the reason? I've got a solution for you. But really look for that reason, and look at what they're not telling you. This isn't a dropout patient who's saying, I don't want to do the contact lens exam this year. I'm never wearing contacts again. But this patient has gone from an annual supply wearer to now over 2 years hasn't ordered any lenses. So really being mindful of those patients and asking, again, good deep questions about why they might be slowly dropping out of those lenses. So again, how many boxes are they purchasing? Are they somebody who is a consistent annual supply? I always tell them, you won't hurt my feelings. This is not the Jen Stewart contact lens brand. If there's something that's not working here, let's fix it. If you want to be a contact lens wearer, let's get you back in those lenses. Let's figure out a solution. You're not going to hurt my feelings. Don't worry. And often that breaks the ice a little bit, and they laugh and go, you know what? You're right. I noticed I'm not wearing them because they are dry. I just didn't want to tell you, or I didn't want to offend you. So whatever it is, let's get in there and solve it for these patients. Let's see. So what is the reason? So asking, and sometimes I think we're afraid to ask because we either are running behind and we want those patients to just be really happy because we want to get to lunch and we've got an emergency in the next room, and sometimes not asking is the easier option, and we don't want to open that can of worms. What's the number one fear of a contact lens wearer? Who wants to share what they think the number one fear? We all know this one. What's the number one fear? Great answer. That if they tell me something's wrong, then I'm going to tell them they can't wear contact lenses. So this is such a fear of these patients. If they say, these lenses are a little bit dry, Dr. Stewart's going to tell me, well, you just can't wear lenses anymore. So again, asking really, really good questions. 50 to 95% of patients who wear contact lenses will report with problems. That's a huge range. So somewhere in there, that's about right. And what are the most common problems? Dryness and discomfort. But often these patients will come in and they won't be verbalizing dryness and discomfort the same way we would. They might be complaining about blurry vision. So we have to really be mindful about what they're saying to us and what our our gut reaction is, or how we do this. And as we have a nice comment here, feelings I am not expressing, fine, everything is fine. So that's a great way to remember that also in your personal life. If somebody tells you they are fine, it might be that they have feelings they are not expressing. So thank you for that. So making sure that we use the best technology available and the best materials available. I know this is not breaking news. I know this is nothing that we haven't heard before, but for me, it's a great reminder for every patient that I walk into that I'm going to walk into that exam wanting to give them the best material, the best design of lenses, and to really keep them in their lenses, because that's our goal. So the dreaded question, I was waiting for this. I was waiting for somebody in the chat to say, but the lenses are more expensive. And if we were live, I would have picked on somebody and gotten you to tell me that. But are they more expensive? Are the newer technologies in material and design more expensive? Absolutely. 100% they are more expensive. And I don't apologize for that. I don't skirt around the issue. I will let patients know myself. There are different lenses available for you that will help you with the dryness, help you with the vision, make you see clearer and crisper, and they are more expensive, and that's okay. Because if I was in a room, I'd ask somebody in the front row to give me their cell phone, and I would love to trade you that cell phone for something on the other side, maybe a car phone, a pager, or a flip phone, although flip phones now are back in, so it just doesn't look like that. So are they more expensive? Absolutely. And as one of the commenters says, does it matter where you live? I don't think so. All of our patients need good quality lens materials, no matter where you live. And if you can impart that value on that patient, that they are going to believe in that. And most of them have a cell phone. That's probably, I don't even know which cell phone I use there. I'm sure that's an older Apple iPhone. I'm sure there's a newer one available since I put that picture up, but most of them would not go back to a pager if they even had a pager. So they would like to have that new technology. It's just our job to make sure they know the value of that. So how do we also think about this? So if you've been on any of the Woo You dry eye, ocular surface disease webinars, you are well-versed in this and better well-versed in this than I am. And if you haven't listened to some of those, make sure that the next time there's a dry eye webinar series that you're on there, because they're amazing. And what people are doing and how they're looking at the ocular surface and the tear film and the lids and lashes is absolutely amazing. And we often think that we should be only doing that when a patient comes in who has really nasty looking lids and kind of gross lid margins or really complaining about ocular surface disease. But being mindful of looking at every patient as though they're a dry eye patient can help you in your contact lenses. And again, as our colleague mentioned, time is of the essence, and a lot of us don't have the luxury of sitting here for an hour going through all of the checklists of things we have to do. So I love to use the talk and scan method. So I use the slit lamp time as a time to talk. I also love when a patient's wearing a mask, because now we're not talking with them in our face. So it makes it a little bit easier, but I use them as a captive audience. So when I have them in the slit lamp, this is the time that I'm asking really good questions, because I feel like the slit lamp is truth serum and they don't know what I'm looking at, but they know I've got a very bright light on their eye. And if I'm asking the question, they're usually going to answer very honestly. And yes, these days, everyone is a dry eye patient. Thank you for that, whether they know it or not. So this is a really great way to be mindful of looking at every patient. Look at their lids, look at their lashes, ask good questions about what you're seeing, ask things about what they're experiencing. Because again, if we want to upgrade them to a newer technology, it's easier to do it when we're using their own words to do it. And we're using things that they've mentioned to then say, here's a solution to a problem you may not have even known you have. This is a great time also to talk about contact lens overwear and sleeping in lenses. Again, it's the truth serum of that light, that beam on their eye, when you can say, I'm noticing this, have you been doing this? And it's very hard for them to lie. when they know that you're looking right at their eyes. So thinking about their blink rates, also, this is a great time to talk about visual hygiene and about blinking and about making sure that they're taking breaks on the screen. You can be looking at how well they blink, how often they blink, and have good conversations around that, all while you're doing the slit lamp. The patient's there, we're there anyway. This is a great time to use that time to really give them some good insight into what you might be noticing. This is hard for me, that sometimes I will have to, we have to tell a patient, I know you really want to wear contact lenses and I want you to be successful. But as our colleague mentioned, everyone's a dry eye patient, whether they know it or not. Sometimes we have to take a step back and tell them honestly that we have to treat their dry eye first if they're going to be successful in contact lenses. I know this is not earth-shattering, but often we have this feeling that we need to do everything at once and we have to do everything in that first exam. I'm just here to remind you that it's okay to tell the patient that you have to treat that dry eye first, because my goal is to get you as successful in those contact lenses as possible. And sometimes it's just not going to happen overnight. And this might be the patient who comes to you saying, 8 doctors have put me in 12 different types of lenses. None of them worked. I've tried, it just doesn't work. And maybe you're going to be the person to do it. And that's when I'll say, maybe I will, but it won't be today and it won't be tomorrow. We do have to have you back for a dry eye workup before we fit a contact lens on you. Again, another colleague, these are the words that we're hearing. I'm concerned about your previous failure with contact lenses, and we can solve that problem first. So we've got some great feedback from some of the attendees on how they manage that. And this, I think, really comes down to communication and gaining the trust of your patients, and really being upfront and honest. And I will say to them, I know that other people have tried. I'm going to be successful with you, and I'm going to work really hard to do that. But there's things we have to do to get there first. So it's okay to have them back. It is okay to tell them that they can't have it today. In a society where we rely on instant gratification, it can be hard, and we can often feel pressured by these patients to do everything in one visit and to do it all at the same time. But really putting your foot down and saying, we have to do all of these steps first for you to be successful. That can become that happy patient that refers to you over and over again. So stand up to them, tell them no, say not now. It's not no, it's not now. So I alluded to this a little bit in the beginning, and I'm guilty of this as well. Sometimes we look at our schedule and we look at the time. We look at our 8, 8:30, 9, 9:30, but we're not looking at the patients. We're not looking at the names. We're looking at their time slot, maybe their insurance, maybe their age, and really kind of, okay, if I can get through this person might be a little longer. And we look at them more as a time slot than we do as a person. And that is we're trying to get through our days. We have a lot to talk about to each patient, but I'm here to encourage you again to stop tomorrow and look at the patient in your chair and look at them a little bit differently. Look at them as a person, look at the needs they might have, look at the things that they enjoy doing, and really think about that they might need more than one solution. And again, that's okay. We sometimes, again, try and put so many solutions in one pair of contact lenses or one pair of glasses, and we don't stop and think that it's okay that they might need multiple solutions for each person. So I have a background in sports vision. I have a sports vision practice that I started in 2015. I see a lot of athletes. I have a lot of patients who are athletes, and I use the term athlete very loosely. If you've ever heard me talk about sports vision, or you've ever been to any of my presentations about sports and vision, an athlete to me is anyone who moves their body. It does not mean that they have to be an elite, a pro, a competitive athlete. It is somebody who moves their body in a sport or activity or a hobby. So I encourage you to look at your patients tomorrow differently as athletes. And it could be an athlete that is 8, and it could be an athlete that's 88. But each of these people that are sitting in our chair have different hobbies and things that they like to do outside of the practice or outside of their exam, and they deserve good vision for those activities. So for an athlete, what I like to think about is they're motivated. So these patients tend to be really motivated to make changes, especially the higher level athletes. they have invested a lot of time and money and effort into their sport. So making sure that we're using the right materials and designs and thinking about them differently and thinking about the patient differently than we would a non-athlete is super important. And I'll get to a service failure in my practice in just a moment. So these are great candidates for daily disposables. It's kind of a pun intended home run. They want the cleanest, clearest vision. And if you can convey the value of that, you should have no problem putting these patients in a daily disposable. Think about the sport they play and think about winter versus summer. Or outdoor time, and think about UV exposure. So when you're fitting them with a lens, really think about what you're doing to protect them on top of enhancing their vision. They may play in a dry, dusty environment. They might have a poor blink rate. If we think about our e-sport athletes, which is a huge growing field, when I'm working with an e-sport athlete, they often have a terrible blink rate because they are sitting and staring at a computer. So really thinking about the lens that I'm choosing for them based on, again, dry eye that they might not even know they have, but how can I give them really crisp vision that's going to be stable? And I love to talk about how I am giving them a solution to a problem they might not have even known they had. And that is a really, really great way to work with these athletes. These athletes really think about how to correct mild refractive errors. I have plenty of patients that I fit -1/4 in one eye and nothing in the other, and it is for a reason. And also think about fitting these patients who have low sill with toric lenses and not spherical equivalents. We're going to get to that in a minute, but I have a lot of patients of mine who might wear a toric lens in one eye and nothing in the other, -1/4 in one and nothing in the other. So often we look at patients in general and think, do they really need a contact lens? Is their vision bad enough? For an athlete, any refractive error should be corrected no matter how small. And this doesn't mean it has to be for all the time. I worked with a lot of high-level hockey players who theoretically have perfect vision, but I would fit them with a -1/4 lens or a plano -75 toric lens that they would wear for either practice and games, but they'd wear nothing the rest of the time. So it's okay to fit an athlete with a low prescription. They will notice the difference and they will appreciate that. And to them, that could be the difference between the level that they play at, because that visual acuity is so significant. I would caution you, if this is something that you hopefully take with you tomorrow, make sure that the whole office knows about your new philosophy on working with patients. We had a situation where I was working with a lacrosse goalie. I had seen, he was a sports vision player of mine for years and years, and he was -1/4 in one eye, plano in the other. We tried contact lenses and he couldn't get the lens in and out. So the INR didn't work. And I said, that's okay. We'll try again next year. He came in next year and he saw another doctor in the practice who I didn't talk to about my philosophy on athletes. And she, rightly so, saw -1/4 and nothing and said, you're fine. And you don't need anything. Great. We'll see you in a year. And the mom said, what about contacts? She goes, oh, you don't need contacts. And the mom goes home and picks up the phone and I get the phone call, Dr. Stewart, we were there today. We didn't see you. How come you had such a different opinion about what my son should wear between the doctors in the practice? So that was a service failure on my part, that I didn't talk about my philosophy, not knowing which doctor the patient would see. So I would encourage you tomorrow to go in with this and say, here's what we're going to do. We're going to start looking at refractive error and correct our patients to the lowest amount possible. But this has to be a whole office philosophy. It can't be depending on the doctor they see, so that you don't have this kind of misstep in what the patient is getting. And the staff should be on board too. There's nothing worse than a front desk or a technician saying, you don't need contact lenses. Your vision's perfect. Let's undo that process and that sale in the pre-testing before they even get to the doctor. Let's plant the seed that they need nothing. And then Dr. Stewart comes in and says, no, you do need contact lenses. So really taking the time to educate everybody. is so important. And we have another colleague chiming in that recently fit a patient with -50 in the right eye only, so he could play softball in the evenings, which is a great time to use that. And I've often done that where in the evening they wear a lens, maybe during the day they don't need it. And his team won the tournament he was in last weekend. So that to me is a definition of a contact lens success. Thinking differently, fitting a patient with a lens that they wear in one eye just in the evening. Is that okay? Absolutely. And our colleague here just saw the success that had. So we've got lots of options for sports, and it might be that you stay on the soft disposable side and you don't tackle some of the more complex lenses available. If you are not comfortable with sclerals or ortho-K or hybrid lenses, make sure you have a colleague who is, and that you can freely refer that patient if they need a higher correction or something that you can't provide. Make sure you have a practice that you can refer to. I did not fit specialty lenses, and it just wasn't what I did, and it wasn't something that I felt I could do. But the great news was I had two colleagues, one north of my practice and one south of my practice. So I would happily send any patient, not just athletes, but any patients of mine who needed a more complex lens fit than I could do. I would make sure that those patients knew there was something else available. So we don't have to do everything. Multiple RXs are okay. If you have a monovision or multifocal patient during the day, they might need a distance only RX depending on the sport they're playing. So if they're playing a racket sport at night and they are wearing monovision or multifocal contacts on the computer, they might need a distance only to play a racket sport at night. Somebody who wears, a distance pair or distance contacts and puts reading glasses over, that might not work for their sport. So they might need a multifocal or a modified multifocal because they can't be throwing their reading glasses on and off. I work with a lot of cyclists. They can't just kind of ride with reading glasses on their nose, where they might be comfortable on their screens with, a distance contact and reading. Maybe they find that having a computer, their bike computer or their watch, it's a better option to have reading or multifocal contacts. Somebody, again, might need a mild prescription for contacts. There is a question about, is it even worth it? Or is it worth the risk? Absolutely. If you're working with higher level athletes, 100%. These athletes we're working with tiny fractions of improvement. So my personal philosophy is if they have a small RX, there is no harm in correcting it. And everyone has their own opinions on that. But if you're working with high level athletes, it's super important. And that could be the difference for them in their career. You can think about ortho-K. So maybe a swimmer who can't wear a soft lens or that chooses that they want to wear goggles. Maybe they wear ortho-K and they are contact lens free throughout the day. I'm going to move through this pretty quickly, but there are some other types of lenses out there. There are, if anyone remembers Nike Maxite from a long time ago, performance tinted single-use contact lenses. Now there's a daily disposable that's out there to help athletes who might not want to wear sunglasses in their contact lenses. Some of the benefits are that it can reduce visual noise, reduce glare. So patients find when they're wearing contact lenses in different situations, if they're a baseball player, they might need to put sunglasses on and take them off, but with a tinted contact lens, they have less glare. It can improve their contrast and overall have sharper vision. So there are two different types of tints on the market, and depending on the athlete and the sport, you might be using amber, which is used for reactive sports outside, so bright sunny skies or overcast. So used for baseball, football, archery, softball, lots of different sports. There's a gray-green, which is used more on water. So if we think about our ophthalmic lenses, the contact lenses are very similar. So this really helps with contrast. So if you have a golfer, a triathlete, somebody who does a lot of sailing and boating, fly fishing, water skiing, these might be a great option. So this is a great practice builder. It's a great way to bring in a lens that they are not going to hear about everywhere. They're certainly not going to hear about this on the online vendors, or it's a great way to differentiate the care that you provide. And again, to think about that patient in the chair as a person, as an athlete, and really give them a customized solution. So this is a great way to differentiate the care you're providing. So if we were in the room, I'd love to see how many presbyopes are in the audience. You can a show of hands. You can even put it in the chat. You give me a thumbs up. How many presbyopes are there out there? There's a lot. So if you're one of the presbyopes, you are in a good club. There are a lot of us. I will say us because I feel like I'm in that group as well. So there's an estimated 1.8 billion people in the world who are presbyopic and more than 111 million presbyopes in the US. This one was hard to type, that the millennials are beginning to turn 40. That was a hard one for me to really wrap my head around, that the millennials, which start in 1981, are starting to turn 40, 41, 42. So, oh, look at all the chats we got. Oh, look at, yes, thumbs up. We got a sad face. Don't be sad. Yay. Lots of presbyopes out there. So the millennials are adding, and the millennial population is larger than the baby boomer population. We heard about for years and years how the baby boomer population was going to change our practice. It's going to be the millennials. And add that to Generation X, which is, I guess, where I fall. So we have 73 million millennials added to 61 million Generation Xers. That's a lot of presbyopic patients who typically have worn contact lenses. Oh, I like the skull. Thank you for the skull. That's the presbyopic skull in our chat. So there are a lot of patients that are turning 40, 41, 42 that have been wearing contact lenses their whole life, and likely are not ready to give that up. So a recent survey of those who are 40 to 45, 90% or 9 out of 10 are frustrated with presbyopia. I love that 10% who are happy as can be and really excited about presbyopia to come to my practice. I think that 10% didn't answer the question or didn't understand it, because I can't imagine that there's anyone out there who's super excited about this change in their vision. But in another survey, 80% almost asked their ECP about near vision issues, but half left without discussion. So this is what I alluded to earlier, that these are not things that we don't know, but it's just a great, great reminder to me that these patients are asking questions and a lot of them are leaving without answers. And I know that to us, presbyopia is something we see every patient every day. But to these patients, it's a question that they have and they're asking for a solution. And what's their solution? A lot of times it's over-the-counter readers. So 32.6 million people wear over-the-counters and they purchase about 51.2 million pairs. We have those patients, I got my 5-pack at Sam's Club or BJ's. They're purchasing a lot of over-the-counters. And is that the best solution for these patients, or can we do better? Here's if you're ever bored, this is a fun social experiment. Go to Amazon and type in reading glasses and see the over 10,000 results and be amazed by the quality that comes out. So, but this is what our patients are doing if we're not giving them the answers. And yes, as much as it stinks becoming presbyopic, it helps to empathize with the patient. So I agree with that comment. And now I feel like I can talk to them a little bit better now that I'm going, oh yeah, that is a little harder for me to see, but we need to be the expert. We need to own this. This is not going away. The aging of America, our population is getting older and living longer. So this is going to be something we're seeing more and more and more in our practice, as we know. So what do we do about it? And I know that this is something we all know, that we need to talk to all presbyopic patients about contact lens wear. Remember that statistic that half of our patients are leaving our office without their questions being answered. Let's get that number to 0. Let's make sure that each one of us is having a conversation with our patients about their needs, about the challenges they're having. And maybe it's not contact lenses for them now, but make sure that we're offering that and make sure we're telling them what's available. Make sure we're embracing multifocals. We're steering away from monovision. I have so many patients that come in and go, oh yeah, I do the 1-in-1. They all do this. I got the 1-in-1. Is that the best option for our patients? 15 years ago, maybe it was, but now with the new technology that's out there in the multifocal world, and how simple it is to fit them, I think we're doing our patients a disservice if we're going right to that monovision. Start early. I started wearing multifocals at 39. So I obviously I had the opportunity to have a fit set there, but I found once my friends started to notice they were having slight changes, fitting them early was easier because they had a quicker on-ramp. They didn't have such a discrepancy of vision going from wearing nothing to a multifocal. But as soon as they started having issues, it was a great time for me to introduce multifocals to them. So make sure we're treating the ocular surface disease in these patients. These patients, again, tend to have drier eyes, and we want them to be successful. So really setting them up for success includes really talking about ocular surface disease. Follow the fitting guide. If you remember one thing from this presentation, hopefully more than one, but if there's only one thing you remember, please follow the fitting guide. It makes your life so much easier. So many times I hear from doctors that they don't fit multifocals because they're too challenging or complex, or it takes too much chair time. If you are using the fitting guide, it will significantly decrease the time and the number of fits and the number of times you have to have them back, which again, it helps drive revenue because patients coming back over and over takes up chair time. Communicate, under promise and over deliver. I usually get that one completely backwards. When I talk to a patient, I tell them I'm going to over promise and under deliver, which does not make for a great experience, but I really try and set them up for success by really emphasizing the things that they are going to need help with. And then when they put their lenses on and they're surprised at how well they see, then I look like the hero. I'm a big fan of using real world targets. I use a cell phone. I don't use a near point card. I really have them do the things that they're doing on a daily basis. And I tell them how you see that near point card only matters if you're me. How you drive your car, pick up your kids, grocery shop, social media, scroll, all of that's important. So get out your phone, let's see what you can see, and let's celebrate that success, because you couldn't read that phone without anything when you came in. It might not be perfect, but it's better than it was. And in a minute, it'll be better. In 5 minutes, in 10 minutes, in an hour, every moment is going to get better. So let's celebrate the success that you were able to see that now. So I know that there's some discussion about my patients prefer monovision. I would just encourage you to try some of the newer technology. Try using the fitting guide to see if you can be more successful and give our patients better binocular vision, better depth perception, better overall vision. I would encourage you, the next 5 patients you have, to really try the newer multifocal lenses that are out there and use the fitting guide and do your best and see what that success rate is. So my last one is astigmatism. I was very proud of my soccer ball and my football. Very proud of that. But does astigmatism matter? So keep it in the chat. Let's keep going with our audience participation. Every person who has astigmatism, please give me a thumbs up. Please give me a hi or something there. Please show me that you have astigmatism. I won't be able to do the math as we go. I'm not that quick, but yes, I'm seeing all yeses so far. Astigmatism, most of my patients, me too. A third of our patients have astigmatism. 32% of our contact lens wearers have astigmatism, yet head scratchingly, only 10% of those patients wear a toric lens. So my rhetorical question to all of you who are saying yes and thumbs up, if you have a patient in your chair, how many of us prescribe the spherical equivalent in glasses? How many of us are actively giving our astigmatic patients their not full correction in their glasses and going, well, it's close enough. You have half a diopter, 3/4 of a diopter, a full diopter of SIL. Instead of writing that RX out for you in your glasses, I'm going to give you the spherical equivalent. So I would ask for a show of hands. Good. I know it's switching from yes to no. So I know that I asked you if you have astigmatism, and now we're switching, and thumbs down. Thank you. No, almost never. So why, if we have a patient who has astigmatism and we are not doing it in their glasses, we're giving them their full correction, and by the chat, I can see that's what most of you are doing. Why is our knee-jerk reaction to give them the spherical equivalent in contact lenses? Feel free to give me your answer in the chat. I'm trying to figure this out as I go, why do we do this? So I know this is not clear. Both of them are a little bit blurry, but if we think about a patient who has a 3/4 of a diopter of SIL. On the left, they have their optimal correction that should be crystal clear, depending on your computer screen. But so often we mask that and we give them their spherical equivalent because it's close enough. And we think that that's going to give them okay vision. They're not going to notice. They're not going to complain. They don't like the cost. That's the biggest one I see is cost. These patients don't want to pay for a lens for astigmatism. Comfort is another. So one of the biggest reasons that patients complain about comfort is not necessarily comfort, but it could be their blurred vision as well. So for those of you who have astigmatism, you know you've made it when there's memes. I mean, how many of us get these memes sent to them on a daily basis? What do patients with uncorrected astigmatism talk about? They talk about blurred vision, it's worse at night, glare, asthenopia, headache, sometimes dryness and discomfort because they're not quite sure how to verbalize how they're feeling. And if you haven't seen these memes, you're lucky. I think I get them sent to me every day. But now astigmatism has made it that this is what patients are sharing, and patients are now aware of what astigmatism is, kind of, and what it looks like to them. So what do they want? And I know a couple of our colleagues had shared in the chat that patients don't want to pay for lenses if they don't have to. So a study was done of 60 habitual soft lens wearers, a range of prescriptions, all the patients you're seeing day to day. And the unequivocal answer was that these patients preferred a toric lens to the spherical. 3.5 times more of these patients preferred a toric lens to the spherical equivalent. 96, almost 100% of astigmats were willing to pay more for a toric lens. So I know our knee-jerk reaction is to give them the spherical equivalent because I don't want to tell them about a lens that's going to cost them more because they don't want it. Again, a lot of times we put our preconceived notion of what a patient is going to pay before we offer them the best solution. I'm here to encourage you tomorrow to make the choice to give every patient who has astigmatism a toric lens, no matter the cost. Even the patients who are low astigmats, the ones that we really don't think are going to notice a difference, and we are really good at giving them a spherical equivalent, 9 out of 10 of those patients were willing to pay more for a lens that gave them clearer, sharper vision at all distances, even at a higher cost. So I encourage you to think about these patients tomorrow. It's really, really, really hard to not give them the spherical equivalent. I am guilty of just, as soon as we see a toric prescription, I think our head starts to calculate it. And again, I want you to sit on your hands, bite your tongue, grit your teeth, do whatever you have to do to change the behavior that we all have. And again, like somebody says in the chat, if we show them how good their vision can be, you'd be surprised what they're willing to pay for. And toric lenses, you guys are writing my whole presentation for me. And toric lenses aren't that much more. So this is coming from your colleagues. These are words that I am reading from the comments. So thank you. I believe the same way, that we just have to impart that value and to show them what they are seeing or what they might be missing. So I encourage you to think about that a little bit differently and present that to the patient, that you're going to give them the sharpest and clearest vision, and it might cost a little more. We have options. There's tons of options. I'm not going to go through all these. This would take me the rest of the evening, but you've got tons of options. Don't forget the presbyopic astigmats. Make sure that you're taking care of them. There's lots of options out there. Again, if these aren't in your wheelhouse, refer to a colleague who does do that. Check their vision differently. Make sure you're using loose lenses. Give them real world examples. Give them lots of time to adapt. Use your lab consultants and fitting guides, and don't be afraid to refer these patients if you can't take care of them. With that, we made it. We made it through all the success. Again, think differently about your patients tomorrow. Think about the patient in your chair as a person who has needs and challenges. Use the newest technology and designs. Listen to that patient and look beyond the lens. I made it. I answered a lot of questions as we went. Here's my information. I am just really excited to be here. I have so much fun presenting this because it inspires me to get out there and do better every time, because I'm guilty of all of these things as well. So I always feel like if I can do better, we all can do better. But thank you. Find me, connect with me on social media. I want to hear your successes.